Let's introduce themselves. My name is Dr. Vivian Jolly B. I'm a breast surgical oncologist and chief of the breast surgery department at New York Presbyterian Brooklyn Methodist Hospital. And I'm going to then pass it off to my colleagues, starting with Dr. Evelyn Tywell.
Hi everyone, thanks for having us here. My name is Dr. Evelyn Tywell. I'm a medical oncologist at NYP Brooklyn Methodist. I work very closely with Dr. B, and we're very excited to be here with everyone. Dr. Balagun's next.
Hi, everyone. I'm Dr. Balagun. I'm a radiation oncologist specializing in breast cancer, and I am thrilled to work with Dr. Tywell and Dr. B.
Great. So why don't we pull up the slides and we'll get started. And I just want to encourage you all to, if there are any questions, to just put it in the Q&A box that's right below, typically on your Zoom. You can also communicate with us via chat, but questions are often best suited in the Q&A box, and we'll look for those questions as we proceed. So today we wanted to talk to you about facts and myths about breast health. And just a little bit of background, three of us, Dr. Tywell, Balagun, and myself, are breast cancer specialists, and we work closely together in a multidisciplinary fashion at New York Presbyterian Brooklyn Methodist, and we're all on faculty at NYP Weill Cornell as well. We have a passion for serving our community, and through this discussion, you'll gain a little bit of perspective as to why that is. Next slide. So I just like to always start out with breast cancer, what we call epidemiology or statistics. When you look at the estimated new cancer cases in the United States for women, breast cancer is the #1 cause of cancer in women in the United States. Next slide. And when we look at the estimated causes of death due to cancer, breast cancer is the second leading cause of death due to cancer in women, only following lung cancer. Next slide. And just because we have a special focus in the Black community, I always like to just talk about numbers in the United States. So according to the US Census Bureau, nearly 42 million Black Americans live in the United States. And of course, this makes up about 13% of the total population, and that's growing. The top 5 states for African Americans are New York, Florida, Texas, Georgia, and California. But as many of you know, many parts of the United States continue to diversify. Next slide. So I gave you the statistics for breast cancer, but what about disparities or statistics as it relates to racial, ethnic differences? So breast cancer, although Black women are slightly less likely to be diagnosed with breast cancer, Black women unfortunately have a 40% higher mortality, or what we say death rate, than white women when we talk about breast cancer. And that slide is illustrated, that fact is illustrated by the chart that's to your right, where the red line are Black women and the blue line is white women. And as you can see, Black women have a higher mortality. Next slide. Now this is due to many factors, but just when we see those numbers, what we call that breast cancer disparities or disparities. And this just highlights that, again, nationwide, the breast cancer mortality or death rate is 40% higher for Black patients compared with white patients. Next slide. When we talk about breast disparities, I know we use that word often, so I wanted to provide some context. It's when the outcome or health status in one group is greater or lesser between groups, and that's illustrated just as we've discussed with breast cancer. And this cause is due to many factors. We call it multifactorial. It could be due to socioeconomic disadvantages, social determinants of health, comorbidities, breast cancer phenotype. So Black women are more likely to be diagnosed with a more aggressive subtype of breast cancer called triple negative breast cancer. There's also factors of medical distrust or mistrust, racial discrimination, racism in the healthcare systems. And so as we look at all of these factors, and I should put in there genetics as well, as we look at all of these factors, it all contributes to the disparity that we see. Next slide. So we wanted to come out here and educate you all so you were aware, because we truly believe knowledge is power. This slide illustrates that, if you can see sort of the pink arrow, that when we look at hormone positive versus hormone negative disease, Black women are more likely to have the hormone negative disease. And Dr. Taiwo may talk a little bit about what that means when we get to the medical oncology section. But the main point is that hormone negative disease is often more difficult to treat and is a more aggressive subtype, associated with a more aggressive subtype. Next slide. This further illustrates that breast cancer tumor biology in Black women across all ages, at the age of 20, above 20, and above 50, associated with the triple negative breast cancer. As you can see, the red bar line illustrates that Black women are more likely throughout all age groups to be diagnosed with triple negative breast cancer. Next slide. And we also see differences in survival across stages. So breast cancer is staged from 0 to 4, and survival is lowest or lower in Black women across all stages. So the breast cancer burden of Black Americans, unfortunately, is higher mortality, advanced stage distribution, younger age distribution, and a twofold higher rate of triple negative breast cancer. And I'm going to pass this off to one of my colleagues to sort of talk about the differences in screening. And, again, knowledge is power. So what I will say is, while I've given you a lot of numbers and we keep saying disparities, our job, and really why we are here, our passion, is to provide you with so much education and knowledge that you can be your own advocate. And so to that end, screening mammograms are so important. And so I'll pass it off to one of my partners to talk about screening.
So I can talk a little bit about screening. I think most women, have heard, as Dr. B mentioned, that you should get a mammogram. And what we're seeing is, of course, with COVID-19, when it came, a lot of people skipped their annual exams. And it's so important that we return to the regular screening, because the earlier we catch breast cancer, the more likely we are to be able to cure it and to treat it effectively. So you may have heard about, that there are different ages that people can begin breast cancer screening. And that's because there are these different organizations that kind of have different recommendations. So for a long time across the board, it was that you should begin breast cancer screening by the age of 40. And you can see at the very top, the first row, the American College of Radiology suggests that you begin at 40. The next row, the American Cancer Society says 45, but there's an option to begin at 40. And then if you go all the way to the bottom, the United States Prevention Services Task Force, that's kind of a group that comes together to look at all of the studies that have been done. They looked at all the studies regarding mammography and said, we think that you can actually begin at 50 and you don't have to do it every single year. We think you can do it every 2 years. So that has caused some controversy in the field. So I think our recommendation to you would be speak with your physician, right? Talk with your primary care doctor or your gynecologist, OBGYN, to think about, what is right for you, especially if you have a family history of breast cancer. In those instances, we usually want people to begin 10 years before the youngest person in their family was diagnosed. So that's just the information behind mammography. And if anyone has things they want to add, certainly feel free to jump in.
Not that I have too much to add. I think you covered it very well. I think it's important to have conversations with your primary care doctors. Those are the people that you see first. I mean, a referral to an oncologist is at the time of a diagnosis of breast cancer. The goal is not to have, develop breast cancer or catch it very early. That being said, we have this different guidelines and recommendations starting from age 40 to 50. I generally follow the American Cancer Society guidelines, but once again, this is a conversation that needs to be had with the primary care physician. And part of the reason, particularly as it pertains to Black women, we talk about Black women being diagnosed with cancer at a younger age. It tends to be a higher stage at diagnosis, and it tends to be a triple negative breast cancer. At least the rates of triple negative breast cancer, the rates are higher in Black women. And so for that reason, screening at an earlier age, which would be the 40 to 45, according to the American Cancer Society, may actually be more beneficial, particularly for Black women, since we tend to have the more aggressive subtype and higher stage.
Absolutely. Okay, well, we've given you lots of information, but now we want to sort of address some of the myths that you may have heard in the community, and then we're going to tell you really what the facts are. Next slide. So I'm going to start with breast surgery myths and facts. Here's a myth that I often hear from women. If I get breast cancer, I have to have my entire breast removed. Is this a myth, or is it true, or is it not true? The answer is it is not true. So just because you're diagnosed with breast cancer does not mean that you have to have your entire breast removed. In fact, there's another surgery that we often do. Sorry, there's noise in the background because we're at the hospital. So I'm going to let it go down. Okay. There is another surgery that we do, and often women are great candidates for, and it's called a lumpectomy, or breast conserving surgery, where we're able to save your breast. So no longer like it was in the 1980s and 70s, do all women require a mastectomy that's removing the entire breast with the diagnosis of breast cancer. Okay, next slide. Myth number 2, if I have surgery for my breast cancer, the cancer will then spread. Is this true, or is it false? So this is a myth, so it's not a fact. I think what happened was back in the day, back in the day, let's say our great-grandparents, great-great-grandparents may have gone to the physician or the doctors, and by the time they made it there, to get treated, the cancer had already spread. And also back in the day, we didn't have great modalities or ways to really look for breast cancer spread. And so I think that's where the association of, cancer spreading with surgery came about. But really, in fact, it's sort of cancer had already spread. It wasn't the surgery that caused it. Nowadays, we are able to really look closely and catch cancer very early. People are coming in to get treated before it's more advanced stage. And there's no scientific proof or evidence that by having surgery or making an open wound that causes cancer cells to spread. Next slide. Fact or myth? If I don't have a family history of breast cancer, I won't get breast cancer. What do you think, Dr. Balagoon? Is this fact or myth?
I think most people think that you're supposed to have a family history of breast cancer, but I feel like I'm cheating because I know the answer.
So the answer is, this is a myth. So, so the myth is if I don't have a family history, I won't get breast cancer. And really, 85% of breast cancers that are diagnosed are actually not associated with a family history. So really the minority percentage of patients who have breast cancer will have a family history. Now, certainly want to know about your family history because it's sort of our spidey senses go up and there are things that we need to look for. But just because you didn't have a family history does not mean that you will not develop breast cancer. Next slide. Okay, go ahead, Dr. Bell.
Yeah, I wanted, so along those lines, I wondered if you could talk a little bit about, so what does cause breast cancer? Because that's what people, if it's not the family, then why am I getting it? You know, if I've tried to live a pretty healthy life, that's what I find people, you know, confused about.
Yeah, I think that's a great question, and we don't know all the answers to it. It's sort of many factors. So environment, you know, eating habits. Of course, tobacco and alcohol have been associated with other comorbidities and cancers. There, we look at social determinants and know that those also contribute to sort of exposures that then may later result in one little cell turning into a cancer cell. What are your thoughts, Dr. Taiwo or Dr. Balagon? I'll throw it back at you.
So I think, you know, exactly what you said. I try to tell people we don't really know. You know, we haven't fully figured it out. So of course, but we know that there are things that increase your risk, like the things that you mentioned. I think sometimes people think about, I just saw someone who was talking about estrogen replacement therapy. So we know that we've known now for some time, at least 2 decades, that there's a form of hormone replacement therapy, you know, replacing estrogen. Maybe you're having a lot of symptoms due to menopause, and there's a form that can increase your risk of cancer. But right now, I think most people put you on a form that doesn't increase your risk of cancer. So that's what else I would add to that.
Yeah.
But unfortunately, most of it is just bad luck, that there are changes in your body. For some reason, the cells in your body that are supposed to die off keep growing, and we're still yet to fully understand why.
Absolutely. Okay, next slide. So, fact or myth, using underarm antiperspirant or deodorant can cause breast cancer. I've heard this a lot in the community. Let's see if this is a fact or a myth. Next slide. So the fact is, there is no evidence of connection between deodorant and breast cancer, but the safety of antiperspirants is still being studied. The way that I sort of look at this is, you know, again, no studies have proven this. I am, as my colleagues know, very pro eating healthy and thinking about sort of chemicals. So I have definitely tried natural deodorants. They don't work well. But I have switched them over, and for those patients or people who want to go that route and do natural, I am in full support. But there is no study that supports that myth. Next. If you maintain a healthy weight, exercise, regularly eat healthy, and limit alcohol, you don't have to worry about breast cancer. Next slide. So although these behaviors absolutely can help lower your risk, they don't eliminate your risk of breast cancer. Remember, we said breast cancer is due to many different factors. So you want to, of course, be careful and thoughtful about what we call those modifiable factors, things that you have control over: alcohol intake, smoking, tobacco use, you know, the way that you eat, maintaining a healthy lifestyle. Those may be things that you can sort of modify. We always encourage exercise and staying active, but those behaviors don't absolutely prevent you from getting breast cancer. Next. This is a good one. Carrying your cell phone in your bra can cause breast cancer.
I've heard that.
I'm going to let you talk about that one.
Oh, I was okay.
This
Yeah,
radiation oncologist.
110%. So, I think our phones work. They're different kinds of energy, right? There's light energy, there's radiation energy, microwave energy. And they've done a lot of or done a lot of studies looking at, for instance, we thought maybe your cell phone would lead to brain cancer, but they really haven't found any evidence that putting the phone near your head, or I don't think they've been able to study breast cancer as much. So they haven't been able to order breast cancer because it's hard to, or they haven't been able to study breast cancer because it's hard to do a study of how many people are putting, phones in their bra. But the main point is that we don't think that that it causes cancer, that it increases the risk for cancer either. So yeah, the long and short is we don't think it does, but it's probably for sanitary reasons better to put your phone elsewhere. So I would recommend, your purse, your back pocket. Okay.
Yeah, all of those places. Absolutely. All right, let's continue with this pink table talk. Next slide. Consuming too much sugar causes breast cancer. Dr. Taiwo, since you're the medical oncologist, let me throw that one at you.
You want me to answer if it's a myth or a fact?
Yeah.
I mean, it's not a fact, it's a myth. So we definitely don't have any data showing a direct correlation of consuming too much sugar. Sugar comes in, many different ways, right? From raw sugar to even the regular carbohydrates that we consume on a regular basis. I mean, it all ties back into being healthy. It all ties back to being how inflamed your body is. We know when we consume a lot of sugar, we have spikes in sugar in our bodies. It means there's spikes in insulin in our body because the insulin works to help metabolize the sugar. And so when you have this spikes of up and down and not a steady state of sugar or a steady state of insulin in the body, it increases the rates of inflammation, and inflammation in general increases your risk. Doesn't directly cause it, but increases your risk of not just breast cancer, but all types of cancers in general and in other non-cancer related diseases. So that's, basically the gist of that.
As a lover of ice cream and a person with a sweet tooth, I thank you. Because
Right.
I think there are some studies looking at exactly what you said, like regulating those spikes, of sugar. But of course, like, a well-balanced diet is the most important thing for anyone. But I find it hard. I'm not going to sit here and, pretend that I eat salads. Dr. B is much better at it than I am.
Dr. Taiwo is better than me.
So I'm the worst, and you guys.
We try to encourage.
Yeah.
Matter of fact, I haven't had lunch today, so at some point we have to go get a salad. Had a great one yesterday, Dr. Taiwo. I'm gonna have to. This happens in medicine. I have to run to the OR, so I'm actually going to pass it off to and the OR is the operating room. I'm going to pass it off to my wonderful colleagues to continue the myths and facts, because I know we've got some good ones coming up. Again, thank you for having me, and I look forward to continuing this sort of journey of educating our community. So I'm going to sign off.
Thank you for saving lives. We appreciate it.
Thank you, Dr. B.
Thank you.
So I don't know if you want to take this on, Dr. Taiwo, or I can, either way.
You can go for it. It's fine.
Great. So myth, annual mammograms guarantee that breast cancer will be found early. And actually, I'd love to, if people don't mind, I would love to have some people put thoughts in the chat, maybe a few ideas about what they think about that. Do you think that if you get your mammogram every single month, that it will guarantee that breast cancer will be found early?
Yeah, every single year.
Exactly. So anyone have thoughts, some initial guesses? All right, well, let's see. Maybe next slide, we'll just go ahead and proceed. So even though mammography is the best tool that we have, it doesn't always find breast cancer at an early stage. So it increases, the likelihood that we're going to find cancer early. So before we had mammography, I think mammography came around in the 1980s. And before, exactly, Jean, you're 100% correct. It is a myth, unfortunately. I wish it was true that we would always guarantee that we found them early. But mammography came about in the 1980s. Before then, we were finding cancer at much later stages. But with mammography, we found more cancers at an early stage, but it's not 100%, unfortunately. So right now, what we're hoping for is to get better and better technologies that can get it to as close to 100% as possible. But there are some women, I will tell you, where they go for their mammogram in March, and then when they come, by the time they come back for the next one, there's a large cancer there. And these are just some cancers that grow much faster than the norm. So those are a small percentage of patients, but you should definitely get your mammogram every year, or if you discuss with your primary care doctor and they say every 2 years, you should do it. But unfortunately, it doesn't guarantee that we'll always find breast cancer at an early stage. All right.
I just
So
want to add one thing to what Dr. Balogun said. Yes, so the screening mammograms are not 100%, accurate in terms of detection. I think in addition to mammograms, I tell many of my patients as women, we really need to know what our breasts feel like. We need to be very comfortable with our breasts. There are many patients who actually present just stating, not with the mask, their breast just feels very different from what they're used to. So get comfortable with knowing what your breasts feel like.
and I love that you said that. I like listening to podcasts, and there was a podcast, Michelle Obama's podcast, and she said that as women, sometimes we can come from societies where it's taboo to touch your breasts, or it's, it might be frowned upon, and it's so important to not let that stop you from empowering yourself, right? To do something excellent for your health, like knowing your breast and doing a monthly breast exam. Okay. So next slide, please. All right. So all breast cancer is treated pretty much the same way. What are people's thoughts about that? I'll just give it a few seconds because we like to hear from our audience. All breast cancer is treated pretty much the same way. All right, can you move on to the next slide, please? So this is a myth, unfortunately. So I think a lot of times what people find, and Dr. Taiwo, you can let me know if this is your experience too. People mean well, right? When they want to share with you what happened with their diagnosis or their mother's diagnosis or their sister's diagnosis. But the truth is that everyone's breast cancer, even though we call everything breast cancer, there are different types of breast cancer, right? How it behaves varies from person to person. And so there are a number of different things that we use to treat breast cancer. So in the upper left corner, you'll see that they called it sectoral resection, but that's just surgery. So we can use surgery. After surgery, you may need radiation or you might need chemotherapy, or you might be recommended to take some pills called hormonal therapy. So it really just depends on each individual, what their cancer is, and what your preferences are. So just keep that in mind when people, even though they mean well, tell you, oh, this is what's going to happen, and that's what's going to happen, and that's what I had. It really varies. Anything else to add?
No, because I think I'm going to address it a little bit when my slides pop up.
Great. And Megan said it's an absolute myth. So, and Lauren said it's a myth as well. So you both were completely right when you said that it was a myth. All right, next slide, please. So I think we're going to now transition to Dr. Taiwo.
Yes, so I'm going to talk about the medical oncology myths and facts. Medical oncology basically is the part of oncology care that manages, when it comes to breast cancer, that manages breast cancer with medications, and there are different types of medications. So basically, this is one question that there's only one kind of chemotherapy and it can't treat any kind of cancer. So we're going to say, is this a fact or a myth?
And Dr. Taiwo, for chemotherapy, what do you mean by chemotherapy?
So when we talk about chemotherapy, I mean, chemotherapy is just medication that generally destroys cancer cells. And I think when people think of chemotherapy, there's this one focus that there's only one type of treatment, and there isn't. When we actually talk about chemotherapy, if you notice, the first slide had chemotherapy in quotes. So like Dr. Balagun mentioned earlier, when we talk about managing breast cancer, there's the surgical part, which involves surgery, there's the radiation part, and then there's the medication part where chemotherapy could be part of the treatment. Sometimes we give patients hormonal therapy, which are sometimes injections, sometimes pills, and then sometimes we treat patients with what we call targeted therapy, such as monoclonal antibodies, which also target specific things in the cancer. I think in general, when people say chemotherapy, they're including the medications that could be IV or could be oral pills. They're also including hormonal therapy, which is actually not chemotherapy. They're anti-hormone drugs that target breast cancer that has hormones, or breast cancers that are fed by estrogen that we make as women. And then we have the targeted therapies as well. So there is not one particular chemotherapy for all types of breast cancers. Some breast cancers require chemotherapy, which are medications that will destroy cancer cells. Sometimes they cause destruction of other normal cells. And when people think of traditional chemotherapy, that's what they're thinking about. But then there are breast cancers that do not require chemotherapy, that may require just anti-hormone therapy, which generally are pills. They're injections, but they're generally pills. And then there are times where it's just targeted therapy that's also required, that's also not chemotherapy. So it's important for patients, when I meet a patient for an initial visit, to not allow, the fear of what they think chemotherapy means to sort of come to a visit with this sort of decision already being made about, oh, I don't want chemotherapy, and you may not require chemotherapy. So it's important to know that chemotherapy means different things, and not all patients require chemotherapy. And even for patients who require chemotherapy, there are different types of chemotherapy drugs. We have to go based on the type of breast cancer, the size or the stage of the breast cancer, the age of the patient's medical history, their ability to tolerate some of the treatments that we're recommending. There's a whole lot thought process that goes into making a decision about what medication is going to be used to treat a breast cancer.
And are all chemotherapy, is all chemotherapy in the form of IVs, or are there some oral drugs? Can I make a decision which one I want?
So there are chemotherapy drugs that are pills. Most chemotherapies right now are still intravenous, which is through an IV, but there are oral chemotherapy drugs. Now, in terms of managing a breast cancer, the type of chemotherapy we're going to recommend, whether it's to suggest, an oral form versus IV, a lot of that also really depends on the type of breast cancer and the stage of breast cancer that the patient has. For patients that we're treating for early stage breast cancer who require chemotherapy, because not all of them do, it's still generally an IV form of chemotherapy we give those patients patients. For some patients, we have oral pills if they're a stage 4, and then sometimes it's a combination of both. So, but I think it's important to just not necessarily know about all the chemotherapy drugs. That's what we do as doctors, but for patients to understand that there are different types of drugs that exist, and then even chemotherapy is a type of drug. It's not the only drug, and there are different types of chemotherapy drugs, and asking specifically about their own treatment.
And I was going to say, you said that's what remembering all the chemotherapy drugs is what we do. It's what you do. God bless you, because there's so many to keep straight.
Yeah.
I do not know as much as you do.
So next slide, please. And so the next question is, chemotherapy is only given for terminal patients. I'm going to go through this really quickly because I know we have some radiation myths and facts to also address. So next slide. So that is a myth, because chemotherapy is not only given to patients who have terminal breast cancer. We actually sometimes do not give chemotherapy to patients who have, when we say terminal, a breast cancer that has spread. There are many types of oral medications that exist for some of the breast cancers that have spread, and not everyone requires chemotherapy. And even in early stage, which are patients that are being treated with the goal of cure, because we can cure the breast cancer, we do give those patients chemotherapy depending on the type of breast cancer they have, the stage of the breast cancer that they have. And generally, when we give that chemotherapy, it's really to try to eliminate any tiny cancer cells that may be in the body that can cause problems in the future for that patient. So chemotherapy is actually not only given to patients that are deemed terminal. We give chemotherapy to a lot of patients with early stage disease, and patients thrive after they've been treated. And chemotherapy basically is just what we call systemic therapy, which is a drug that is, whether it's oral or whether it's IV or whether it's an injection given under the skin or into the muscle. These are just drugs that travel through the body, through the bloodstream, right? So you take it by a pill. If your body absorbs it through the stomach, it goes into the bloodstream. We give the medication through an IV, it goes to the bloodstream and then goes to the areas where the cancer cells are or could be. And basically that's why we give chemotherapy in patients who are not stage 4. And then in patients who are stage 4, we may give chemotherapy to also reduce the disease burden. So the conversation in a patient who's got breast cancer who's being told they require chemotherapy is not because they are deemed terminal. It's sometimes because the risk of a recurrence is relatively high in that particular patient, and we still have the ability to destroy those cancer cells before they cause problems in the future. So it's not terminal. That's a myth. Next slide, please. I think this may be my last slide. I think we addressed this earlier, that chemotherapy is only administered intravenously, and we do know that that is a myth. Next slide, please. We have different forms of giving chemotherapy. Like I mentioned earlier, that chemotherapy just is basically medication that is traveling systemically, going into the bloodstream, and there are different ways of getting medications into the bloodstream. So for breast cancer, we have chemotherapy that we give intravenously. We have chemotherapy that we give through pills. We have anti-estrogen, what we call hormonal therapy that we give mostly through pills, but we also have injections that we give through the muscle. And then there are actually some liquid forms of anti-estrogen medications that exist. So it's not all intravenous. But I think that the whole point of this, my 3 slides is just sort of trying to take the fear out of what it means to get chemotherapy. Not everyone who has a breast cancer requires chemo. And for those who require chemo, it doesn't necessarily have to be IV. Most of it is IV, but there are pills that we give, there are injections that we give, and not everyone who requires chemotherapy is getting chemotherapy because they're terminal, and not everyone who's considered terminal requires, and when we say terminal, stage stage 4. I actually don't use that word. Terminal is generally when I have that conversation for patients that are no longer responding or they really become debilitated from their disease. Stage 4 does not mean terminal. I have stage 4 patients that are in their 10th year of being treated for breast cancer. So it's absolutely important to just have that conversation. You know, this is really to eliminate fear. And I think my last slide is my last slide, actually. Next slide, please. That there is no hope for stage 4 breast cancer. This is also a myth. I just addressed that. Can we go on to the next slide, please? This is just a picture that's showing 5-year survival. And obviously this was up until 2012. We're still working on data for, 2020, 2021. And if you look at, 5-year survival from the 1990s to, 10 years ago, it's basically doubled. So we've been able to just develop new drugs. We're learning so much more about, breast cancer. Patients are living longer. So it's so important to understand that, there is hope. There's always hope for all types of breast cancers, including patients that have stage 4 breast cancer. And this is actually very important to sort of segue into the importance of clinical trials. The reason we've been able to see significant improvement in survival of all types of breast cancers is we've been able to, assess, how patients are doing, how they're responding to some of the new drugs that are available. And so it's important for women of color, particularly Black women, to ask their oncologist about available clinical trials. We're still very underrepresented in a lot of the clinical trials, and that's probably contributing to some of the disparities that we see in survival in breast cancer with Black women compared to white women and other groups of women. So there is significant improvement in survival, but we're still not there when it comes to Black women. So we need to sort of be proactive as doctors and as patients. It's important to ask your oncologist, if you do ever get a diagnosis of breast cancer or any cancer, are there clinical trials available? Clinical trials are leading to people living longer with their disease. So this is the end of my slide. It's all you, Dr. Balagoon.
I just love what you've said, the fact that there is hope, right? There's hope for stage 4. It is not a death sentence, and just showing that we've made so many strides, but that, in certain subgroups, in certain minoritized populations, there's still a way to go. Wonderful. All right, so we're going to go through some radiation therapy facts and myths now. So first, radiation therapy is painful. So I have it all on one slide. So it's not true that radiation therapy is painful across the board. So what is radiation, first of all? Radiation are x-rays, right? I think most of us have had a chest x-ray. You couldn't see the x-rays. You can't feel the x-rays. Sorry about that. That's a dog. You can't see the x-rays. You can't feel the x-rays. You don't necessarily hear the x-rays. And in some people, radiation to the breast can cause swelling and some discomfort. And the severity of that varies from person to person. And unfortunately, we haven't gotten to the point where we can predict how bad the breast pain or swelling will be. So that's just a myth that it's across the board, very painful. One thing that people frequently worry about is that while they're getting the radiation, they'll be feeling a lot of pain. And that's just not true either. While you're on the table getting treated, you're not going to feel like a stabbing pain or anything like that. Okay. All right. Next slide, please. So radiation therapy will make me radioactive. And I put, Storm or Halle Berry from the X-Men here. Unfortunately, it won't, right? I'm not going to give you any special superpowers or anything like that with breast radiation therapy. There are some instances where people use special radioactive seeds for other cancers, and they place them inside the body and leave them there permanently. So in like prostate cancer, people sometimes do that. They'll take small, radioactive seeds the size of your nail or smaller, and put them inside the prostate, and that will make the person radioactive for a certain period of time. If people have thyroid cancers, they'll have to drink something that will make them radioactive. But for most cases of breast treatment, you will not be radioactive. All right, next one. All right. Oh, so this just refers to the fact that in breast cancer, sometimes they can put a device inside your breast. Looking at the right side of the screen, that picture is just showing that in some women, we may have to put a device inside the breast. This is not most women, actually. It's less than 5% of women, or less than 10%, depending on where you are, have this kind of treatment where we would use this balloon inside the breast to deliver radiation. So even in that instance, you're not radioactive. And on the left side is the machine that we usually use to treat breast cancer patients. So it's called a linear accelerator. And you are going to be lying on that black table right there, and the machine will rotate around you, giving radiation. So it doesn't last too long. You're usually on that table for, let's say, 30 minutes the first day, 15 to 20 minutes following sessions, but that does not make you radioactive. Okay. All right. Next one. So radiation therapy will burn me. I hear this from a lot of people. The honest truth is that some people will have skin reactions that are severe, right? So in some instances, people will have the skin peeling off. Okay. There's some situations where we have to intensify the dose to the skin. And let's say your breast cancer was advanced and it involved the skin of the breast, we're going to have to make sure that we treat the skin and get, a high dose of radiation to the skin. So in those instances, you're going to have more skin side effects. Your treatment team will prescribe medications to kind of decrease the severity of those side effects to get the skin to heal. But usually you're not going to get a burn like that. You're not going to have open skin. In certain cases, you will. Most commonly, people will have breast darkening and some redness. The intensity of that darkening or redness is dependent on a person. And we haven't gotten to the point where I can say, well, your skin is going to get dark to this extent. So hopefully in the future, we're working towards it. We find that Black women do tend to have more pronounced skin reactions. But I would ask your physician to maybe show you some pictures of what it looks like. I try to show pictures so that people aren't caught off guard, so you know what to expect, because it may be very slight or it could be very dark, okay? And we want to make sure that you're not caught off guard. So next slide, please. Radiation therapy will cause me to lose my hair. So I completely understand. I know it's a concern, but if you're getting treatment to the breast, radiation is like surgery. Where we treat is usually where it affects. So if you're getting treatment to the breast is what's affected, not your hair. If you're receiving chemotherapy, right? And maybe Dr. Taiwo, you can talk a little bit about hair loss with chemotherapy and what they can do about that. But if you're getting treated to the armpit, right, for radiation, then you might expect to lose hair in your armpit. It will, ultimately grow back. I'm not giving you like the ultimate, wax, for free, but usually you're not worried about the hair loss on the head as a result of radiation therapy for your breast cancer. If the cancer travels to the brain and we have to treat your brain, then you may expect hair loss. So I'll let Dr. Taiwo talk a little bit more about hair loss and chemo.
Yes, no, that's a good point, because we're women. We generally love our hair. It's all part of how we identify. So hair loss is definitely a huge cause of distress for many patients who are getting chemotherapy that causes hair loss. So majority of the chemotherapy regimens that we give patients who are getting treated with breast cancer will cause hair loss. The hair loss is not permanent. Most patients will start gaining some growth within a few weeks of being off chemotherapy. We also do have ways to prevent hair loss. There's a device called a scalp cooling treatment. It's actually approved by the FDA. It's still not covered by insurance, but we're working on that. But it's a device that patients can wear during their chemotherapy treatment. It cools the scalp. It basically causes the blood vessels in the scalp to sort of constrict, which means it causes those blood vessels there to tighten up a little bit, which then reduces the risk of chemotherapy being transferred to the blood vessels in that area, and then reduces the risk of hair loss. They've done studies showing that it's very effective in most women who use it. It doesn't prevent complete hair loss. There would be a little bit of hair loss, but most patients are able to keep most of their hair, at least about 70% of their hair. We do have the machine available at our site, actually, here at NYP Brooklyn Methodist. We have a scalp cooling machine, and we're actually working on creating a trial to see how effective it is in Black women, because most of the studies that have been done and published were done in white women here in the US, and then in Asian women, because Asia in Japan was where the initial study was done in the 1990s. We don't have very good data in Black women. There were Black women who were included in some of the studies here, and it appears to be very effective in those women, but we want to do a study that's actually focused on just Black women to confirm that it actually works. So there are ways to reduce hair loss, but that is one thing for patients requiring chemotherapy. Most chemo, not all, but most, it's something that is unavoidable without the scalp cooling. So we do have that option too for patients who feel very strongly about preserving their hair during treatment.
Wonderful. All right. So I think this is my last slide because I do want to give us, I think we're getting to the end, but I want to give us at least a few minutes for questions. So radiation therapy increases my chances of developing more cancer. And if you can click on the next slide. Yeah, so that's not true. So, this cycle, people think, oh, I was diagnosed with cancer. If you give me radiation, then I'm going to get another cancer. So the risk of a second cancer from radiation treatments is very low. They've done a lot of studies looking at this, and I can say confidently that for most individuals, it's less than 1% chance, even less than, in many cases, less than like 0.1% chance of you developing a second cancer due to your radiation therapy. Usually it takes over 10 years for the second cancer to come back, and most people will not have a second cancer develop. There are conditions. There are people who have certain changes in their genetic material, in their DNA, that puts them at a higher risk, right, for having a second cancer develop due to radiation. And in those instances, you want to speak with your doctor about, this is something that I know about my family, or I've done a genetic test and they told me that I have this condition that increases my risk of developing a second cancer after I've had radiation. So, we would talk with you about, what's the benefit of getting radiation versus the risk of the second cancer, and weigh them and make a decision about proceeding with radiation. But for most instances, the risk of a second cancer is less than 1%. Okay, next slide, please. I think that's it for, oh, sorry, last one. Radiation will cause nausea and vomiting. So if I'm treating your breast, it should not cause nausea and vomiting. Radiation to the stomach, to the brain, can cause nausea and vomiting, but there are ways, even if you're getting it to those areas, there are ways for us to manage those side effects. But if you're just having breast radiation, it should not be a side effect, okay? All right. And then I think that is, I've talked about some of these side effects of radiation treatments, the feeling tired, the skin changes. So you can move on to the next slide. And we talked about that your physician, your treatment team will prescribe different things to take care of the side effects. So if you're fatigued, rest, moderate exercise and stretching helps if possible. And then for the skin, you can use calendula lotion, aloe vera, the plant that you get in the office. There's specific skin ointments that they might suggest. And then, there are a list of other things that people can use to manage the side effects, but discuss them with your doctor if you're going through treatments. All right, next slide. So thank you so much, everyone. We're open to questions. We just have a few minutes left, but we would love to hear from you. Any questions you have, put it in the chat and we're happy to address them.
Any questions? Someone asked, how can people become involved in studies? That is a great question, and I love that people are asking that. So there are different types of studies. We have studies that are looking into how patients respond to a type of treatment. There's studies that are available where we're just asking specific questions from patients, sort of more survey questionnaire type questions, type of studies. So it really depends on the type of breast cancer that a patient has. There are studies that are looking at patients who are early stage versus patients who are metastatic. So I think how to get involved in a study really is asking your oncologist if you've been diagnosed with the breast cancer. Part of the conversation about how to manage your breast cancer should be, are there clinical trials that I may benefit from? There are certain treatments that are pretty standard where there are no real questions about how these patients are being managed, where we're not doing studies because we know that our current standard of care is very appropriate, has very good survival and very good responses. We may not be doing studies in patients that we know this is the standard treatment. You're definitely going to do fine. Well, not definitely, but you're probably going to do fine. There may not be studies available for some of the standard things, but it should always be part of the conversation. And your oncologist would tell you about studies that are available either at that site or at other sites. So, but that's a very great question.
And I think Jean followed that up by saying, is having cancer a requirement for the trials?
So that's a sort of a big question. So I mean, we're oncologists, so all the patients that we're seeing are generally patients that have a cancer or have had a cancer. So there will be studies, looking actively at patients that are being treated for a cancer. There will be studies looking at patients who've been diagnosed with a cancer. But a patient without a cancer probably could be involved in non-cancer studies, and that would be with a non-oncologist. It may be with an epidemiologist. So, but those are still questions, because I think it's important for us to also gather data from patients who don't have cancer that could actually help us in our goal of being able to eradicate cancer in the future. But once again, as a cancer center, because we're oncologists, we only see cancer patients. So yeah, all the patients that we enroll in our trials here are cancer patients, but that's not to say our colleagues who are treating non-cancer patients don't have studies available. So it's just a question to be, that needs to be asked to your doctor.
So 110%. So one other thing I wanted to highlight, when we were talking about mammograms before, there's all this controversy. When should you start? How often? So I encourage people to join the Wisdom study. So I put the website link in the chat. Basically, it's a study that's trying to find out, based on you, right? Based on your features, what is the best screening, what are the best screening recommendations for you? So they're using a combination of, your age, your family history, Plus, they're adding in your genetics. They're doing a genetic test, and there's certain genes that are associated with, a higher risk for breast cancer. So it's really a beautifully put together idea and trial. And you don't have to have breast cancer to be on that study. And you can actually enroll through the internet. So I urge you all to, check that out, thewisdomstudy.org. If you're interested in participating in trials, but you don't have breast cancer, that would be a great one to be involved in. Let's see. So someone else wrote, how often should you self-check for lumps, and how often should you see a professional to check if you are under 40? So that comes from Mia Harris. Thank you so much. So in terms of self-check exam, if you look online, there are a lot of differing opinions. Some people say doing a self-exam doesn't add anything. I personally would still encourage women on a monthly basis to do a self-exam. There are a number of women who find it on their own. And as we mentioned, in between mammograms, sometimes people develop cancer. Not that many people, but some people do. So I would still encourage doing your own monthly breast self-exam. And it varies how often you should go to your doctor and get a breast exam. But I would say it's safe to say annually, right? You're supposed to do an annual checkup, just like as an adult person going in, just to make sure everything is fine. So for both of those, for the clinical exam, I would say one with your doctor per year is fine. For the breast self-exam, usually, once per month would be fine. Dr. Taiwo, thoughts?
I agree 100%. I have absolutely nothing to add. You covered all of that. Yeah.
Great.
There's a question here. It's a really great question from Catherine Carter.
Yeah.
And she asks, should you seek a second opinion? How can a patient identify the best doctor or facility to treat them? I love that question. And it's one where it's so important for patients to feel empowered. I say if you feel like your questions haven't been answered, I think patients generally would ask for a second opinion if they're asking questions that they're not getting answers to, or if there's some discomfort with the physician who's taking care of them. The discomfort doesn't necessarily mean that the doctor is not great. It may just be there's something about the interaction with the patient and the doctor that's just a little off. So I always tell patients, if you want to get a second opinion, absolutely get a second opinion. Every oncologist should be very supportive of a patient who wants to get a second opinion. Generally, the care is standard. So, most patients who get a second opinion would often get the same response. And I think sometimes patients need to hear the same response to feel comfortable with proceeding with the treatment. Because then if this doctor is saying this and the other doctor is saying the same thing, it makes you feel comfortable with proceeding with the treatment that you may have reservations about. And then in terms of identifying the best doctor or facility, I think when it comes to a facility, you want to be at a facility where they treat there's a large volume of the type of disease that you have. If you have a breast cancer, you want to be at a facility where there are doctors who specialize, who are experts in that particular disease type. And so that's the most important thing in terms of identifying a facility to treat you. And identifying the best doctor is a combination of both. A doctor that you're comfortable with, a doctor that you feel like is able to answer your questions the way that makes sense to you, and a doctor who's not annoyed by you asking questions and who's not annoyed by you saying, how would you feel if I get a second opinion? I mean, I've actually had a few patients who've asked for a second opinion. They usually all come back, but they just want to be very clear that, your recommendations are, they have some, they've come in with their preconceived notion of what they think you're going to tell them. And if you tell them something different, then that throws them off. And sometimes they want a second opinion, and we support that. And patients will usually come back after that. So I think that that would be my advice. Dr. Balogun, what are your thoughts?
110. I echo everything you said. Maybe I once had a friend or a colleague who said, if a doctor actively does not want you to get a second opinion, flip the table and walk out. Because, every physician should be able to stand by what they're recommending.
Right.
And I've had instances where people outright refuse to discuss a patient with me. I will tell patients, I want you to feel comfortable. I am not offended if you get a second opinion,
Yep.
because I stand 100% by what I said. And
Right.
frequently your colleagues will say, yeah, I would do the same thing. But I know of physicians that will not encourage you, will feel offended that you're getting a second opinion. If that happens, to me, it's a red, it is a red warning sign. So everything Dr. Taiwo said, having someone who has expertise in it, 110%. There's one question here about someone said that their friend had an inverted nipple, right, Jean, that could cancer cause an inverted nipple. And it's true, that's one of the ways that cancer can present if it's new, right? If they've had that inverted nipple since childhood and it's still inverted, then the odds are that it is not a breast cancer that's causing the inversion of the nipple. But if their nipples were usually pointing out and now it's inverted, I would say that is definitely grounds for them to, if they haven't already, gone to see their physician and gotten a mammogram. So the other ways that breast cancer can present, of course, sometimes frequently these days we're catching it on mammograms. You may feel something in your breast. Sometimes people can, breast cancer usually isn't painful. Sometimes, if it's gotten much bigger, then there can be some pain, but it's usually a painless lump. You may have nipple discharge. So sometimes people can notice that they are leaking from their nipples when they should not be. And that's also a warning sign. And sometimes you can have very red skin, right? That's a different form of breast cancer called inflammatory breast cancer. So if your skin suddenly, becomes red, now if you have to think about, did you do something? But if there's no other cause and you're noticing very red skin, please come into your physician, because that could be breast cancer as well. Are there other presentations that I'm missing?
No, I think we addressed all of them. And I also put the hospital and the breast centers link on the chat. You can access myself, medical oncology, Dr. Balagoon, radiation, and Dr. B on there. And we have other colleagues working in the breast cancer center as well. So for additional questions, you can reach out to us and, we can take it from there.
Great.
All right.
Oh, Raymond had another one. What are the chances of men having breast cancer? So did you want to help address that, or happy to tackle this together?
We could tackle it together. You go first, but that's a great question too.
Yeah. So for women, their risk of having breast cancer is, I think it's still at 1 in 8. So like 12.5% of risk throughout your life that you will have breast cancer. Men make up about 1 to 5%, or is that less, of breast cancer patients? So it's not common for a man to have breast cancer, but when a man does have breast cancer, we have to think about certain things. And I think I'll let you take that, right? The genetic aspect of it, Dr. Taiwo.
Right. So Dr. Balogun gave some numbers in terms of chances of men having breast cancer. So it's rare, but men do get breast cancer. I've had a few breast cancer patients. And like Dr. Balogun said, most men who are diagnosed with breast cancer actually do have an inherited gene, the BRCA2 gene, which is one of them. There are many genes that can increase your risk of breast cancer. BRCA, which is the breast cancer 2 gene, is the one we generally see in men who are diagnosed with breast cancer. It also increases the risk of prostate cancer, not just breast. So, but Breast cancer in males are also very treatable. We generally treat it whether it's with surgery, radiation, chemotherapy, anti-hormone pills if it's needed. There are a few things that we know also increase the risk of breast cancer in men. So men who are born with an abnormal chromosome, something called Klinefelter syndrome, could also increase your risk of breast cancer. Men who are on some medications that it can increase the estrogen levels in the body. There's a medication called spironolactone, which is used sometimes as a diuretic. Those are, so drugs that are in that class could increase the risk of breast cancer. So it's rare, but we do see it, and it's also very treatable. So if there's a man who has some abnormality, they have nipple discharge, the breast feels odd, it's not, it's not completely unreasonable to be concerned about breast cancer and to present to be evaluated for that.
And I think, right, Beyonce's father had breast cancer. I don't know of any other really notable individuals who have had male breast cancer, but you taught me something maybe long ago, Klinefelter's,
Yes.
that it has an increased risk. You guys, Dr. Taiwo knows everything.
No,
So
she doesn't.
yes,
But
she does.
we all feed off of each other. And that's the thing. Treatment for breast cancer really is what we
Yes.
call a multimodality, multidisciplinary way of treating cancer, because there are different aspects. I know a lot about the medical oncology, the medicine part. Dr. B is an expert and the expert when it comes to breast cancer. And then Dr. Balogun is all about radiation. So it's really wonderful to be at an institution and a facility where you have experts at all things. I can answer sort of basic questions, but when it gets more complicated, then you refer them to your colleagues. And so we generally are all taking care of the same patient. So there's this sort of collaborative, effort to make our patients well. And a patient is not a stranger to all the doctors because we all generally know the patients. So that's the
Exactly.
beauty of this.
I think along the lines of what you've said, well, first of all, I've never worked anywhere. Not I've never worked anywhere, but just working with you and Dr. B, as well as all our other colleagues at the breast center is such a delight, because I respect your opinion. I know that you are passionate about delivering excellent care. So when we're all on the same page, it's wonderful. And you were mentioning multidisciplinary care. We meet once a week, and together as a group, we review all the patients, and that makes sure that we're not missing anything. Because I always tell people 2 heads are better than 1. Imagine 10, from, as you were saying, all the different specialties, surgery, radiation, medical oncology, pathology, radiology, the people that look at the images. So all of us, and genetics, right? We can't forget Catherine. I don't know if she's on the call, but we have all of those experts looking at your case and thinking about how do we get you the best outcome possible. So that's what I'm very happy to be a part of, that kind of system.
Right.
So I think that's it. There may be one individual, they can stay behind, but or I can provide them I'll provide email, but I think that wraps it up for us. Thank you all so much for joining, and we look forward to doing this again.
Yes.
Have a great Friday and weekend.
Take care, everyone. Bye.
Bye.